and welcome to the second episode of the Chat with the Expert series. My name is TK and I'm the Regional Projects Officer from the International Pharmaceutical Students Federation Asia Pacific Regional Office, IPSF in short, IPSF APRO in short.
Hi, my name is Christy, Public Health Coordinator under IPSF APRO.
IPSF is the leading international advocacy organization for pharmacy students with the aim to promote improved public health with provision of information, education, and professional initiatives. So we are from the Asia Pacific arm of the IPSF.
For this series called Chat with an Expert, we engage in a conversation with an expert who has specialized knowledge about a specific disease or a specific area of practices or about a specific public health issue. We are discussing diabetes today.
So today we have Professor Nigel Unwin with us. So Professor Unwin was a medical officer back in 2003 to 2005. He was a medical officer with the Diabetes Union at the World Health Organization in Geneva, and he helped to lead a joint World Health Organization International Diabetes Federation programs of work. He is currently the Professor of Diabetes at the European Centre for Environment and Human Health at the University of Exeter Medical School. So his role there as a Professor of Diabetes is to focus on the links between human nutrition, food production, the systems, and planetary health.
He was also Professor of Public Health and Epidemiology, and now he's an Honorary Professor of Population Health Sciences at the University of West Indies. Also at University of West Indies, he contributed to the development of new graduate training programs in public health and to research on the epidemiology, prevention, and policy responses to diabetes and related non-communicable diseases. Lastly, he is currently a Director of Research in Global Public Health at the University of Cambridge on part-time basis.
So with that, we'd like to welcome Professor Unwin. Hi, Professor Unwin. Thank you for joining us and good to see you here. Could you, for the audience of the video today, could you tell us a little bit more about yourself?
Sure. Well, thank you. First of all, thank you very much for the invitation. Thank you for having me. As you say, my name's Nigel Unwin, and I'm at the moment based in the United Kingdom, and I have a position with Cambridge University and also with Exeter University. And I still have an honorary position with the University of the West Indies in the Caribbean, which is where I was based for a few years until 2016. I'm trained in medicine, so I'm a physician by background, but then I trained in public health many years ago now in the 1990s. And really from that time, I've had an interest, a research interest, but also a public health interest in terms of appropriate public health policies for understanding and responding to the determinants and causes of diabetes especially, but related diseases that are related to similar determinants, and that includes cardiovascular diseases, it includes several cancers. So I had a long-term interest in understanding, why some populations have high rates of these diseases, why some groups within populations have higher rates than others. And as I say, with a focus on diabetes, type 2 diabetes, but also a little bit broader. And I've been lucky enough over the years to work with colleagues in the UK, of course, so I'm working in different parts of the United Kingdom and looking at the distribution of diabetes especially, but these other diseases between different groups in the United Kingdom, different ethnic groups. So people of Chinese, people of South Asian, people of European origin, for example, but then also to work with colleagues in Africa, especially, so in Tanzania and Cameroon and South Africa. And then more recently, I was lucky enough to spend 6 years working in the Caribbean. And some of the work I do is still going on there in the Caribbean countries and a little bit also collaborating with partners in the Pacific, so in Fiji in particular. So that's my background.
All right. Thank you so much, Prof. Unwin, for a very interesting introduction. So, Prof, we'll just jump right into the questions, right, on diabetes. So, I think my first question to you is, I think people are getting more aware of diabetes as the time goes on. So, despite the increased knowledge and awareness, right, from your experience, why is diabetes, especially type 2, is so hard to tackle for populations?
That's a great question. And I think the answer to it is that what causes, if you like, the upstream determinants, so the things that ultimately drive our diet and physical activity. So the proximal, the close determinants to the individual or to individuals are to do with what people eat, how physically active people are, how that relates to their risk of overweight and obesity. So we know that those are very strong risk factors, and there are other risk factors as well, which we could go into, but we know that those especially are very important. But it's no good stopping there and just telling people to eat better or be more physically active, because we know that doesn't work. So if you have an environment, a built environment, a food environment that encourages a certain type of diet, that encourages a certain type of level of physical activity or levels of physical activity, then that environment is very difficult for individuals. I haven't put that very well, but that environment actually is the overall framework in which groups of people choose their food and are able to be physically active or not. So the answer to why it's so difficult is because it's the way our societies are structured. It's the way at the moment that work is structured, our living arrangements are structured, and the way we get our food and consume our food. And there is a tendency the world over for environments in which people live in to be what have been described as, and it was, I think, Boyd Swinburne who first used this term, as obesogenic. You know, there are environments that encourage or make it difficult to be physically active, if you like, you know, encourage low levels of physical activity and encourage a certain type of diet that we know increases the risk of type 2 diabetes. Yeah. So I think the answer is it's in the structure of our societies, and actually societies are becoming more similar in some of these fundamental determinants, you know, across the world. So if you like, what you could be called the kind of urbanization, modernization are making it harder and harder to prevent diseases that's related to, you know, certain types of diet and physical inactivity.
Wow, thank you so much, Prof, for the overview and I think the very tough question to answer, right? Why is diabetes, especially type 2, that is so hard to tackle? So I think you talked about this this obesogenic environments, am I correct?
Yes, yeah.
That we talked a lot about, and oh my God, there were many factors that were being mentioned about determinants. So Christy, I think she will ask you, she had a few questions regarding determinants.
Okay, thank you, yeah.
Yes, thank you. So what I want to ask is that since you brought up the several individual factors of reasons of diabetes, so we would like to ask you about what cultural factors there would be for developing chances of diabetes.
Yeah, that's a really good question, and that's a question. It's a question I don't feel as well qualified to answer, in the sense that I'm not an anthropologist and I don't feel I'm a good student of what culture is. And I also know that, you know, talking about cultural determinants can also be very sensitive, because people often feel very protective about the cultures they come from. So I'm giving those caveats, and I think one should be careful about talking about culture. But I think clearly it is the case that there are different types of food cultures, for example. So that would be one thing. And there are, certainly in my experience, and that's maybe the best place to start, there are different, in some settings and in some groups within some populations, there may be certain beliefs around what's a healthy diet. And those beliefs may or may not align, if you like, with epidemiological evidence as to what's the most healthy diet. There may be some beliefs around what's a desirable weight, what's a desirable body shape and body form, and that might influence. And there's certainly, from the UK, for example, we did a small study many years ago now and found that this was in the north of England, that what was medically recommended, which is to have a body mass index of below 25, you know, many people actually didn't think that was a healthy weight, and actually being a little more chunky, if you like, and having a bit of a stomach, that actually that to them was healthier, that appeared healthier, and that someone was more robust and stronger if they appeared like that. So that's an example of how culture can interact. There are some examples from some parts of the world where, to do a physically active job is associated with poverty. And so that you actually want to do a job that is perhaps more desk-based, because that's seen as having a higher status. There are some parts of the world where, for very understandable reasons, as you get wealthier, you want to be able to afford, perhaps sometimes in inverted commas, what might be called more Western type of food items, more branded types of food items, maybe perhaps to be able to eat more meat, for example, more red meat in particular. And you see that has been associated with improving your quality of life. So there are these types of ways in which culture interacts. And perhaps the last thing to say, I think there are many examples. As I say, I don't think I'm the best person to talk about culture. But one other example I've come across quite strongly is that, in many poorer countries and poorer sections of the population, they don't have access to personal motorized transport. And so there's more walking, maybe use of bicycles in some settings. So as you get wealthier, part of the benefits of becoming wealthier, perhaps, is to be able to afford motorized transport. But of course, you then lose the physical activity benefits of walking and cycling, or, using public transport that typically involves more walking if you start to use your own motorized transport. So I think it's complex, but you can think of lots of ways in which cultural beliefs interact with what people eat and how physically active people are.
I see. So, as you brought up the poor income country and high income country, as you compared, like there were more walkings, more, services they can have in higher income country. So you mean that income can actually affect the chances of developing diabetes, right?
That's correct. Yeah, that is correct. But you need to you need to look into how is income related. So in low-income countries, and I'm generalizing here, but there are studies that show, for example, that in, let's say, low-income countries, and I've worked with colleagues, as I say, in Tanzania, where certainly going back a few years now when I was involved in that work, it was these relatively better off sections of the population who had a higher prevalence of type 2 diabetes, and they had more obesity and were less likely to be physically active. For the types of reasons we've just been saying, they had access to different types of foods, they did different types of jobs, their transport was different. So you would say there, it was positively associated with higher income for those, because people in the sense were, had greater access, if you like, to an obesogenic environment, as we've just been talking about. But I think the one thing I do want to say is that nonetheless, in urban areas, even amongst poor sections of the population, the prevalence of diabetes was still what you would call high, I would say. It could still be, amongst adults, it could easily be 10% or 5 to 10%. And that's still a high prevalence of a chronic condition. And the other thing worth saying is in poor countries, even if the prevalence is high in the richer sections of the population, the impact, if you have it as a poor person, can often be greater, because you are the relative cost of medical care, of treatment, the potential cost of complications such as foot problems or the need for renal treatment can be much more expensive, and the threat to the livelihood of your family, if the person with diabetes is the breadwinner and then they have a problem, they have something that prevents them working, can be much greater. So that's the situation in poorer countries. In richer countries like the UK, type 2 diabetes, the prevalence is higher in poorer sections of the population. So it's reversed. And in actually one country, I worked in Barbados in the Caribbean, as I mentioned. I worked in the Caribbean, and in Barbados at the moment, there isn't really a social gradient with type 2 diabetes, at least not in the studies we've done. So my hypothesis would be it's in the process of going from being higher in the wealthier to being higher in the poorer sections of the population, as is the case in the UK, as in the case of the United States or Canada or places like that. And there it is associated in the poorer sections of the population with high levels of obesity, definitely. But then you have to ask, why are the high levels of obesity? And that's often because the food environments within which people are shopping and the food that they can afford to buy, and perhaps to some extent cultural beliefs around what's desirable food and what you should be pushing on the table for your children, for example, perhaps some of that. But most importantly, the food environments and what people have access to and can afford is worse. You know, they have worse access to, they are tending to eat and have access to more obesogenic type foods, to use that term. Yeah. So more, I don't know if you're familiar with the NOVA classification of foods, but more ultra processed foods. So the NOVA classification refers to 4 main groups of foods. So un or minimally processed foods, ingredients, then highly processed and ultra processed. And there's increasing work to show that it's the increasing consumption of ultra-processed. What ultra-processed refers to are foods that require some kind of industrial process to create them. So most of the things, let's say, many of the breakfast cereals you'll find on supermarket shelves would be classified as ultra-processed. Much of processed meat, etc. And in somewhere like the United States, roughly 50% of calories on average come from ultra-processed foods. So they're so different to what you would have bought at a market stall, you know, which would be un or minimally processed. And in the UK, it's approaching 50% as well. Yeah. So so often, so you would expect to find in richer countries, poorer sections of the population would be tending to eat, on average, higher proportion of ultra-processed foods compared to richer parts of the population.
I see. Thank you. It was very informative, as you have brought up like so many examples in different countries. Like UK, United States. What else? Like Tanzania.
Tanzania, yes.
Yeah. Caribbean, and so it was very informative, and thank you for that. And so as we talk about as you mentioned, the ultra processed food, right? It kind of come to my mind that like the eating environment affects like people eating patterns, and so like it would affect the diabetes, right? Like the distribution of fast food restaurants in countries.
Absolutely, yes.
Yeah. So those part, like, can you further elaborate more on like eating environments of the society, how it can affect to the developing diabetes?
Yeah, sure. So I think that the eating environment, so the food environment, and let's try and just describe that a little. You've already described it very well, but you know what's available. So if let's take urban areas. So the majority of humans now live in urban areas. In the country I live in, it's 80% plus live in urban centres. The world over, it's above 50% now. So if we're thinking of urban areas, then where do people get their food from? Where do people source their food? So where can they buy food to prepare at home, and what type of food can they buy? So that's something to consider. And I maybe simply ask people listening to the podcast to think about, you know, where do they source food? How easy is it to source fresh fruits and vegetables, for example, unprocessed products? So many shops, and again, perhaps this is especially the case in poorer countries, but it's also the case in poorest areas of rich countries. You know, a very high proportion of the foods available will be processed or ultra processed. You know, they'll be on the shelf. They will stay for a long time. They don't need refrigeration, a lot of them. And these tend to be ultra processed foods. And obviously they're convenient because of that, particularly for people who can't store foods. And they may be convenient because they're easy to prepare as well. So that's one area, is where people are shopping. And of course, what proportion of food is consumed outside the home? And that varies. That can also be cultural to some extent. I mean, that varies between different settings and different cultures. In some settings, street food can be very healthy. It can be, prepared from fresh ingredients. In others, it's more of the type, street food, to use that in a general sense. If we think of fast food and fast food outlets, it can be much more of the type you've just described, and without mentioning any big brand names, certain type of chicken or certain type of burgers. And I'll give you another example. So actually, in Barbados or in Jamaica, where I've also worked and collaborate with colleagues, there's a very well-known US brand fast chicken, takeaway chicken, which of course is deep fried and comes with fries and coleslaw, which isn't necessarily the healthiest because of the dressing that is on the coleslaw. And these are very popular and seen as real treats, And one of the interesting things actually in Jamaica is that particular brand, if you ask people, many people think it's a Jamaican brand and don't realize it's a US brand.